Thank you, everyone, for coming today. I'd like to welcome Patsy Catsos from Nutrition Works to give us a talk on the FODMAP diet and food sensitivities and how to counsel our patients on these topic areas. And Patsy completed her bachelor's degree in nutrition at Cornell University, and she received her master's degree in nutrition at Boston University, and completed her dietetic internship at Beth Israel Hospital in Boston. And Patsy is the author of two books, IBS Trio Last, which she explains more about how-to books, as well as Flavor Without FODMAP cookbook series. And she's working on a new cookbook at this time. So I think we're all really excited to hear this talk and get some more information about FODMAP. So thank you very much, Patsy.
Well, thank you so much for inviting me. I'm really happy to be here and see some of your faces. You know, we've corresponded for years via fax, but we don't often get to actually see each other. So thanks for joining me today. Susan Quimby, the owner of our practice, is in the back of the room there, and so thanks for coming, Susan, to give me a little moral support here. So I see patients 3 days a week at Nutrition Works, usually one-on-one, and almost all of my patients have some kind of digestive disease or disorder or concern. And many times those do get into the subject of food sensitivities and intolerances. And I think, you know, there's a lot of crazy stuff out there about food sensitivities, right? So it's important to know your source. And I just want to say a few things about my point of view as a registered dietitian, that my practice is really evidence-based and it's very customized, you know, for the patient based on a nutrition assessment. I don't believe there is any one-size-fits-all type of diet. You know, it's not the kind of practice that tells everybody who comes in the door to go on a gluten-free diet or, you know, comes from any particular diet philosophy or point of view. You know, we work with our patients where they are, and we, you know, if they come to us on a gluten-free, dairy-free diet, you know, that's where we start with them. But we try to stay experimental rather than use a lot of rigid food rules with our patients, and the goal is always to get them eating the most varied and nutritious diet that they can tolerate. So an adverse food reaction that's a really broad term, and it refers to a link that's reproducible between ingesting a food and having an abnormal response to that. We're going to focus today mostly on FODMAP intolerances and a few related things. And so I'd like to show you, first of all, quickly what FODMAPs are. FODMAP is an acronym. It stands for fermentable oligo, di, and monosaccharides and polyols. Most patients really aren't interested or wanting to get into the biochemistry of all of this, so of course we stick mostly to talking about food. But they do want to know that FODMAP is that the acronym refers to a group of certain sugars and certain fibers in the diet that can cause symptoms. And I think it's helpful sometimes to put FODMAP in context of other adverse food reactions. Some people come in and they're just kind of a mess. You know, they think they have all kinds of things going on, some of which may be actual classic food allergies over here on the immune-mediated side of things. Some of which may be immune-mediated, but not necessarily a classic food allergy. So this might include things like celiac disease or non-celiac gluten sensitivity, or people who get headaches when they drink red wine or eat chocolate. Those are immune-mediated. FODMAP intolerance is over here on the non-immune-mediated side of things, and it includes some of the more familiar culprits like lactose intolerance and so on, and also other non-immune-mediated food sensitivities do exist, and they could be related to toxins in the food, or food chemicals, or even like a mechanical irritation from eating too much popcorn if you have ulcerative colitis, that kind of thing. And a single food could cause any one of these various types of adverse food reactions. Wheat is a good example. You can be allergic to wheat. You can have celiac disease related to the gluten in wheat. You can have a FODMAP type intolerance to it related to the type of fiber in wheat, or you could even have, you know, wheat that has spoiled that might have ergo, that toxin that developed in it. This shows you how complicated wheat is. You know, there are many, many different components to the wheat that can cause issues, and FODMAP would be the fiber in the wheat, but that's only about 10% of wheat, so there's a lot of other potential adverse food reactions that could be going on. And then the processing and storage of the food adds a lot of other elements that could cause issues for some people. So the tough part about this whole subject is that there really aren't any good biomarkers for these adverse food reactions. There are a lot of sort of shady tests out there, I guess you could say, that attempt to test people for food sensitivities. You know, the IgG panels that you probably see are patients bringing in sometimes, for example, or, you know, skin prick tests that I see advertised on the internet and even locally sometimes. But none of them are really clinically proven. As far as the intolerances go, you know, you can order breath tests for your patients for, you know, lactose malabsorption or fructose malabsorption, but unfortunately they're not that clinically useful because malabsorption is actually physiological. You know, if any of us drank half a gallon of apple cider, we're going to malabsorb some of that fructose, but only some of those people that malabsorb fructose or even lactose are symptomatic. So not everybody who has a positive malabsorption breath test is going to be symptomatic, and vice versa. You can have people that actually do not have a positive breath test who are in fact experiencing symptoms of intolerance to lactose. So really, elimination diets are the best tool we have to help patients figure out what their food sensitivities and intolerances are. And I think they're far superior to just having people keep a food and symptom diary. This bag is a picture I took of one of my patients who had been on a food and symptom diary journey for many years, with all those notebooks she brought in. But she really wasn't getting anywhere with it. An elimination diet is really patient-specific. It is a temporary learning diet, not a permanent dietary restriction. And I think it really helps to avoid overgeneralizing. You know, if you tell the patient to go on a gluten-free, dairy-free diet, that might not, that's probably in many cases overkill because it might only be one component of the wheat products or the milk products that are causing symptoms. So are elimination diets too much work? What do you think? I've been at several presentations where people have expressed the opinion that elimination diets, especially FODMAP elimination diets, are just too complicated and too much work for patients. But, you know, patients are limiting their diets on their own, and so I think that we can help them learn a lot more from that process by supporting their trial of an elimination diet. You know, I probably don't have to tell you the statistics about IBS, you know, but I'll tell you a few anyway. That it's the second leading cause of work absenteeism. It's the 6th most frequent diagnosis in primary care. I can tell you lots of stories about patients who have lost their jobs related to their IBS or, you know, severely had to restrict their family activities because of their IBS. So I think if you ask patients, they will tell you, many of them, that they'd really be willing to try almost anything to get rid of their IBS. And this is a statistic I came across recently that says it all, I think, that reduction in quality of life is such that on average, these IBS patients would be willing to sacrifice 10 or 15 years of their lives for an immediate cure. So we're going to delve a little more deeply into what FODMAPs are and where they are and how we deliver this diet. So some specific examples of FODMAPs include the following. The O in FODMAP stands for oligosaccharides. These are short-chain fibers, and examples include fructans, which are the type in wheat, GOS, which tend to be present in beans. I guess everybody kind of knows what happens if you eat too many beans, so that one's not a surprise. Inulin is found in chicory root, and it's often added purposely to high fiber foods to boost up the fiber content of those foods. And nuts and seeds and a lot of those good for you things that people are actually often trying to increase in their diet can provide a heavy load of oligosaccharides. The D in FODMAP stands for disaccharides, primarily lactose, which is a disaccharide of glucose and galactose, and it's found in milk products. Some milk products have far more lactose in them than others. Monosaccharides, specifically fructose, also known as fruit sugar, and widely present in all fruits, certain vegetables, and of course added to our food in the form of high fructose corn syrup and honey and agave and other sweeteners. Polyols are also known as sugar alcohols, and when they're added to sweetened sugar-free foods, they're easy to spot on the food label because they tend to end with OL, so xylitol, mannitol, maltitol, and so on, but they're also naturally present in certain fruits and vegetables. All FODMAPs have three characteristics that define them as such. They are poorly absorbed or potentially poorly absorbed. They are rapidly fermentable by the normal gut bacteria, and they are osmotically active. And it's nice to talk with a group of people that don't have to have that term explained. I'm sure you're all familiar with osmotic diarrhea. The effects of FODMAPs are cumulative in the diet, and this is what's really new about FODMAPs. I mean, we've known about things like lactose malabsorption and the fact that beans are gassy forever. But what's new is recognizing that they act in a cumulative way, and so FODMAPs from all these sources are important, and we learn more if we eliminate all of them in the diet for a short period of time than we do if we just eliminate them one at a time. Also, the FODMAP intolerance is load sensitive. So unlike a classic food allergy where the person could have anaphylaxis with, just a little speck of peanut, or celiac disease where the standard is so very, very high for gluten-free diet, with FODMAPs, the effect is cumulative. So we can often get people back to a point where they can enjoy a lot of these FODMAP-containing foods as long as they don't overdo it. This is just a little illustration of the mechanism. The time available here today won't really allow me to go through the entire proof of concept and all, but this is just an illustration that the way that these FODMAPs tend to cause symptoms is by creating an extra load of gas in the gut through bacterial fermentation and an extra load of fluid from that osmotic effect, and that can have unpredictable results. It's not always diarrhea, which is what you expect and what you think of when you start talking about osmotic effects. Depending on the type and amount of bacteria that are resident in the patient's gut, the fermentation aspect might actually be quite a bit more predominant, and we're finding that people who are colonized by methane-producing microbes tend to be constipated. Interestingly and happily, I think, the breath lab at Maine Medical Center just started measuring and reporting out methane if you send a patient for a breath test of any kind, and that's really valuable new information because it's going to help cut down on those false negatives that we were getting. So that distension of the gut can also affect patients because patients with IBS tend to have more visceral hypersensitivity. A lot of people aren't very aware of what's going on inside. You could have two people who might eat a bowl of chili, and of course they're both going to have extra gas from the fermentation of the GOS in the beans, but one person feels nothing, might just have a little extra flatulence and think nothing of it, and the next person could be in quite a bit of pain because they have visceral hypersensitivity. This slide is a little bit hard to read, but I especially wanted you to have it because of the reference it provides, which is a really good overview by Peter Gibson and Susan Shepard, who incidentally were the researchers in Australia at Monash University who created this concept. I met Dr. Gibson when I went to Monash myself to try to learn from the experts over there. I've never met Susan Shepard though, but anyway, this provides some ideas about a management strategy. This was a 2012 paper, and I think it's interesting to note that in the time since then, their subsequent writings and research are pointing away from breath testing most patients as part of this process because of the lack of clinical utility that I was describing previously. They've done a couple of papers specifically showing that even under the best circumstances of absorption, that some of these FODMAPs can create symptoms for patients. So how do you know you've got a good candidate for a FODMAP elimination diet when you're looking at one? Well, they should have a diagnosis of IBS, preferably. Has had a proper evaluation, and I think it's important to rule out celiac if you're thinking of asking someone to try a FODMAP elimination diet. The reason for that, of course, is that the symptoms are very overlapping at times, but also a low FODMAP diet is a very low gluten diet. So if the person goes on a low FODMAP diet and then never wants to eat wheat again, they've lost their last chance to ever have a workup for celiac disease. Because if they've been on a gluten-free diet for a long time, the antibodies and even the biopsies would not pop for celiac. So that's important for a number of reasons for them to know whether they really have celiac disease or not. Because if they do, they've got to be, meet that 100% gluten-free diet standard for life. And if they not, they can afford to make exceptions whenever they'd like to if it's really just IBS. I'm seeing more patients sent to me with the diagnosis of small intestinal or small bowel bacterial overgrowth recently. That's kind of a newer idea, and there's not a lot of really solid clinical guidelines for diagnosis and treatment yet, but I do believe a FODMAP diet is appropriate for a patient with that condition, but diet alone wouldn't be enough. So that's why that should be considered in some cases before just trying the diet. So another ideal candidate for the diet would be a patient with inflammatory bowel disease or celiac disease who's still symptomatic, even though they're either in remission or on the gluten-free diet. About 40% of those patients also have IBS. And then you don't want to just skip right over, the standard therapy for IBS. If the person, tries eating regular meals and eating more fiber and getting more exercise and drinking more water and so on, and if that helps them, then that's great. That's definitely what they should do first. But if they fail to respond to that, low FODMAP elimination diet might be a good next step. Then, of course, they have to have a diet history that's consistent with the problem. If somebody comes to me with the FODMAP education requested, but they're not eating any FODMAPs, they've already put themselves on a very restricted diet out of instinct, or maybe they've already read about FODMAPs elsewhere, so they're already on a low FODMAP diet, but still symptomatic, well, they're not really going to gain much by the process. They also have to be willing and able to adhere to the diet. So if you have, some 85-year-old guy living in a long-term care facility, he's not really going to be in a position to take on a dietary experiment. He'd be an example of somebody with no control over his food life. Also, patients with poor cognitive skills might not be great candidates for the diet because it really does require a lot of attention to detail. And I'm always extremely cautious to screen patients that I think might be at risk for an eating disorder, and I would probably not suggest a restricted diet of any kind to a patient like that. I would probably work from, informed by my own knowledge of FODMAPs to help them make a few specific changes to their food choices rather than ask them to do this whole dog and pony show of the elimination diet followed by the food challenges. That is the plan in general, though, with appropriate patients, is to eliminate all the FODMAPs from their diet for a few weeks. If it helps, which it will help about 75% of those patients, then they go on to reintroduce FODMAPs to the diet, one group at a time. We monitor symptoms, and then they go forward to modify their diet as needed. The goal, and I always say this from day one, and your support would be very useful in this area, is I want to make sure they know that our eventual goal is to get them eating the most liberal diet they can tolerate, not to be on a permanent diet restriction. And of course, my priority is always on the nutrient-rich foods, getting the beans and the greater variety of vegetables and all of that back in their diet. I'm not really worried about whether they can ever have high fructose corn syrup again, but the patients sometimes have different priorities. These diets do work. There are quite a few studies now that have demonstrated that they do help up to about 75 to 85% of patients who are appropriately selected. This was the cover story last year in the January issue of Gastroenterology, and so also there was mention of the FODMAP approach in the 2014 guidelines that came out last summer from the American College of Gastroenterology for the treatment of irritable bowel and chronic constipation. So it's becoming more and more mainstream as an approach. Not surprisingly, patients learn more the closer they stick to this diet. That really makes sense. For really adherent patients, you can get an even higher success rate. About 85% of them respond to the diet. And what predicts adherence? Liking the taste of the food on the diet, finding it easy to incorporate into their life. And I think that's where a dietitian who's trained in this approach can really shine. That's what we do. We help patients translate their dietary necessity into actual plans for what they will eat. The next couple slides contains a brief list of high and low FODMAP foods, and I think most of you have one in front of you at your seat as well. But the patients really need more than a list of high and low FODMAP foods. I mean, it's a good start, but as you've heard, there's a whole process that goes into the learning experience of using this information. Here's the situation your patient's facing when they go to the grocery store. It's pretty overwhelming. I think all of us have probably been there, just trying to pick out a simple product for ourselves. So we have about an hour to spend with our patients at the initial visit, and if the assessment demonstrates or convinces me that we have a good candidate for the FODMAP diet, I spend most of that hour helping them understand what FODMAPs are, helping them with label reading, recipe modification, and drafting a sample menu for each and every one of them if I possibly can. That's something that's really personalized so that they can put it into action when they leave. Then they come back for the second visit typically, and if they're willing and able, some of them really are not ready yet. Some of them want to just stay feeling good for the first time in 20 years. So, I let them lead the pace of the reintroduction. But we plan a very careful process for reintroducing FODMAPs while isolating the variables so we can tell what is provoking symptoms. And if they come to me already on a more restricted diet than I think they might need to be, I'll try to work them through the process of distinguishing whether it's FODMAPs or gluten. Is it lactose, or do they really need to be on a dairy-free diet? And there usually pretty psyched when they find out they don't have to be as restricted as they thought they did. We can't gloss over the fact that there are some potential risks for this diet. You know, I'm sure you noticed that many of those high FODMAP foods are full of nutrients, full of fiber. And so, you know, we have to acknowledge that unless it's carefully planned, the FODMAP elimination diet really can affect nutrient intake. We know that the process of bacterial fermentation of those prebiotic fibers provide a lot of health benefits. So we don't want to minimize intake of prebiotics unless we absolutely have to. And yet, so far, the studies that have looked at the stool of people who've been on these low FODMAP diets haven't demonstrated any decrease in short-chain fatty acid production, although the overall bacterial load has been reduced. So this is something we'll have to keep an eye on, and it's an area of active research. So I'm just going to finish up with a case study that I think illustrates a few of the most important points of our talk today. My patient was a 61-year-old female. She was recently divorced, and sadly, it really was, at least in part, that divorce was a direct partial consequence of her IBS. Her husband had a job that took him to Australia for most of the year, and she couldn't travel with him because she had such unpredictable bouts of diarrhea, and he ended up finding somebody else over there. He got lonely. So she is trying to put the pieces of her life back together. She's overweight, she's got a lot of anxiety and a few other nutrition-related medical conditions. She has to use anti-diarrheal medications every day, and her symptoms are pretty severe. And her anxiety about the symptoms keeps her home when she should be out, you know, being more active, going to exercise class and so on. She doesn't want to go anywhere because she never knows when she's going to pass gas. Her diet history is that she had been a Weight Watcher for many years, and as you probably know from your patient contact, there's a lot of encouragement in that system to eat unlimited fruits and vegetables, which she was doing. She had toyed with eliminating gluten and dairy, but she didn't really know any significant improvement. She was eating a lot of high FODMAP foods, and she did have a tendency to have small binges on fruit and sweets. Incidentally, speaking of high fiber, I just wanted to mention that a lot of these high fiber products that people are interested in adding to their diet do include inulin or chicory root or other new functional fibers that are really poorly tolerated by people with IBS. Even some fiber supplements themselves are full of FODMAPs. Here's an example of I think this was a Chewy Phillips Fiber Good with 8 grams of straight-on FODMAPs in it, 8 grams of inulin. That's a lot of inulin. So sometimes these attempts to increase fiber content backfire on our IBS patients. So I put her on a FODMAP elimination diet, taking into account some of her other medical concerns, and she felt great. She really did well. She was able to stop taking the anti-diarrheal medication and really just was enjoying how she felt. Because of her anxiety, we took a real cautious approach to reintroducing FODMAPs rather than creating a big challenge for her. And, you know, she did very well over the next year or two. I've seen her now for 3 years, I think. In fact, now she tends more toward constipation, so we've really had to work at increasing her intake of low FODMAP fiber. And yet she still has a few bouts of, you know, really pretty unpredictable and severe diarrhea. But we've been able to figure out over the years that this is almost always related to entertaining or going out to eat. And those social situations are stressful for her, and she tends to eat too much, and often followed by a bout of IBS symptoms. She learned through the reintroduction process that really there were 2 of those 4 FODMAP areas that were the biggest problem for her, the polyols and the oligosaccharides. And so she has had to completely eliminate onions, garlic, and mushrooms from her diet. But most other foods she can have in moderation without consequences. She does keep wheat to a minimum because she notices her constipation gets worse if she eats a lot of wheat, but she can have a piece of bread now and then if she's at a restaurant without a problem. You know, whether that represents a non-celiac gluten sensitivity or not, we probably don't have any way to find out. So we learned from Joan that too much of a good thing as far as the healthy high fiber foods is a problem for some patients. Eliminating just one FODMAP at a time didn't produce any usable information. Anxiety or other medical conditions can really affect the way the diet is delivered. And although FODMAPs certainly aren't everything, they can definitely, if you can get somebody's symptoms managed well enough on a low FODMAP diet, you can sometimes help them understand other issues that might be affecting their digestion. So FODMAPs are common IBS triggers. Low FODMAP diet really works. FODMAP elimination diet is a temporary learning diet, not a permanent diet prescription. And got to get those high FODMAP nutritious foods back in there as best we can. So that's my last slide, but I have time for some questions if you have any.
What about probiotics?
Good question. So are you interested in whether they're
helpful, harmful?
Okay. I think they're helpful.
Yeah.
I do think they're helpful. I don't usually introduce them to a patient in the middle of this process. I try to keep them doing whatever they were doing before in every other way except for food choices. So if they come into me on a probiotic, they stay on it typically. If they do not use a probiotic initially, by the third or fourth visit, I might be talking about introducing one.
And are they all, is one better than the other?
I do think that some are better than others. I do a little consulting for VSL number 3 disclosure. That's one I think is really strong for especially inflammatory bowel disease, but also IBS. My constipated patients do really well on a line. That's my go-to for constipated patients. And there are several others that have a lot of clinical evidence to support their use in IBS, and so I would look for, you know, Culturelle, one called LP299V, that's not a proprietary strain, so it's in multiple products. Some patients do well with S. boulardii, which is a yeast-type probiotic and can be very helpful for patients that are on antibiotics because the antibiotics won't kill it. And you do need to have kind of an arsenal of different products because we just don't know enough about the gut microbiome yet to be able to pick out a great match for the patient on the first try. Sometimes you need to progress through a few different products before you find one that the patient really thinks is helping them.
So you're putting the majority of your patients on probiotics. So I'm presuming that you feel like that is important.
If they improve a lot on the low FODMAP diet, but there's still room for more improvement, that might be my next step. But it's not something I do automatically.
I find when patients introduce these probiotics, they often are hit by a lot of gas,
yeah,
abdominal discomfort.
Mm-hmm.
How do you
almost all of those capsules can be opened very easily, and they can just sprinkle a fraction of a capsule on some cold food or in a glass of water and consume a fraction of a dose and work their way up to a whole dose. That can really help with that transition. It's often transitory, though. If they can stick it out for a week, they'll often pass.
So one question I get very frequently in female patients is there an association with my menstrual cycle and IBS? Like, you know, people patterns emerging. I'm sure that you've had these conversations.
Yeah.
So what's your response?
That is an extremely common observation. People's digestive complaints, whether they be diarrhea or constipation, do tend to worsen right around the beginning of their period. that's not going to change by changing the diet.
You mentioned different dairy products at different levels. Each week, which one?
Sure. So as a point of reference, a glass of milk has somewhere between 11 and 13 grams of lactose, an 8-ounce glass of milk. Greek yogurt has maybe 4 to 5 grams of yogurt in one of those 6-ounce cups. Cheddar cheese has virtually no lactose at all. Yeah. So that explains a lot, because sometimes people are like, I had a job once where I was developing menus for people that just couldn't figure out why these lactose intolerant residents that they had insisted that they could have cheese without a problem, and that's why. Lactose is associated with the whey in milk, so any processing that drains off whey, like the process of straining Greek yogurt to make it thicker, or making cheese where you separate the curds and whey at the beginning of the process, anything that discards the whey will get rid of most of the lactose, and then if it's fermented, you know, the cheese culture, the yogurt culture will consume even a little bit more of what's left.
So ice cream pie.
Well, interestingly, ice cream is really hard to generalize about because cream is low in lactose compared to milk. So if it's an iced milk, like most soft serves, or if it's like a cheaper store brand type ice cream that's going to have the cheaper ingredients in it, milk, or if it is a frozen yogurt that's marketed as a low-fat product, it's going to have more lactose in it than the rich ice cream. Yeah. You can buy lactose-free ice cream now. Their Lactaid brand makes several flavors. Breyers makes a couple flavors. And I've noticed that although they're not bragging about it on the front of the package, that a few of the Haagen-Dazs varieties are made with lactose-reduced milk, if you read the list of ingredients. Yes?
So maybe not directly related to this diet, but if you're going to recommend a fiber supplement to a patient,
Yeah.
certain brands or types you would recommend over?
Yes. The one that I would suggest most often would be psyllium husk, and that's the active ingredient in Consul and old-fashioned Metamucil.
I've been hearing lots of complaints about all my elderly patients. Old-fashioned Metamucil is getting hard to find.
Well, I'm not surprised, but you can just buy ground psyllium husk in a jar. You know, it doesn't have to be all jazzed up with orange flavor and sugar and.
Does have in it though? And
You know, I don't believe so. I'll double check that for you. Yeah, I don't believe so. I'll check that and get back to you. Consul is another brand name that has the active ingredient, the psyllium husk. The Consul original is plain, no sweeteners, no flavors. The other one that is not fermentable is Citruscell. Cellulose is not a fermentable fiber, so it doesn't meet the definition of FODMAP.
Well, thank you.
You're welcome. Thank you so much for inviting me. It was really a pleasure, and we really appreciate the opportunity to work with your patients, and we value your trust.
Thank you. Very good. Well,
Thank you.
we'll be able to report this recorded. Others who are not here.
Okay, and if you want to make up a little,
No, I don't know.
it'd be easy to do
Thank you. I'm not sure exactly how to.
what that process will be.
Thank you.
I do give a lot of US out. People have to